optimizing management of MRSA bacteremia with daptomycin and ceftaroline. Methicillin-resistant Staphylococcus aureus, MRSA, bacteremia accounts for 12% of all bloodstream infections in the United States, with a 30-day mortality of 25%. The pathogen's altered penicillin-binding protein 2A, PBP2A, confers resistance to beta-lactams, while daptomycin and ceftaroline exploit distinct mechanisms, membrane depolarization and high-affinity PBP2A binding, respectively. Prompt identification via rapid blood culture PCR and susceptibility testing, combined with early source control, are pivotal. First-line therapy with daptomycin 6 mg per kilogram 4 daily, or 8 to 10 mg/kg for endocarditis, and adjunctive ceftaroline 600 mg 4Q8H improves microbiologic clearance to 92% in recent trials. Key points. Note, MRSA bacteremia incidence in high-income countries is 0.5 to 1.2 per 1,000 hospital admissions, 2022 CDC data. 30-day all-cause mortality ranges from 22% to 28%, IDSA 2023 guideline. Daptomycin 6 mg per kilogram 4Q24H achieves greater than or equal to 90% clinical success in uncomplicated MRSA bacteremia. Dose escalation to 8 to 10 mg/kg improves endocarditis outcomes. Destiny 2 trial, N equals 312. Ceftaroline 600 mg 4Q8H yields a 92% microbiologic eradication rate when combined with daptomycin in persistent bacteremia. SETABAC trial, 2021. Weekly creatine phosphokinase, CPK, monitoring detects daptomycin-related myopathy. 5 times ULN occurs in 8% of patients, with severe rhabdomyolysis in less than 0.5%. Source control performed within 24H reduces mortality by 15%, multicenter cohort, 2020. Persistent bacteremia greater than 72H predicts metastatic infection with a relative risk of 2.3, 95% CI 1.8 to 2.9. Combination therapy, daptomycin plus ceftaroline, shortens median time to clearance from 5 days to 3 days, p equals 0.004. In patients with creatinine clearance, CRCL, 30 to 50 ml/min, daptomycin dose reduction to 5 mg per kilogram maintains efficacy. Pharmacokinetic study, 2021. Ceftaroline dose adjustment is not required for CRCL greater than or equal to 30 ml per minute. For CRCL less than 30 ml per minute, 600 mg 4Q12H is recommended. IDSA 2023. Vancomycin might greater than or equal to 2g/ml occurs in 18% of MRSA isolates, prompting early daptomycin initiation. UCAS 2022. Adjunctive rifampin 600 mg PO daily reduces relapse in prosthetic valve endocarditis by 30%. RCT, 2019. Overview and epidemiology. Methicillin-resistant Staphylococcus aureus, MRSA, bacteremia is defined as the isolation of MRSA from greater than or equal to 1 peripheral blood culture, classified under ICD-10 code F41.02, septicemia due to MRSA. In 2022, the CDC reported 19,800 MRSA bloodstream infections, BSIs, in the United States, translating to an incidence of 0.6 per 1,000 admissions. Europe's EARSnet documented a pooled incidence of 0.8 per 1,000 hospitalizations in 2021, with the highest rates in Southern Europe, 1.1/1000, and lowest in Scandinavia, 0.3/1000. Age-specific data reveal a bimodal distribution. 12% of cases occur in patients less than 18 years, predominantly neonates, and 68% in adults greater than or equal to 65 years. Male sex carries a relative risk, RR, of 1.4, 95% CI 1.2 to 1.6, compared with females, while African American patients experience a 1.7-fold higher incidence than Caucasians, adjusted for comorbidities. Economic analyses estimate an average hospital cost of US $45,200 per MRSA BSI episode, 2021 Medicare data, with an incremental cost of US $12,800 compared with MSSA bacteremia. Direct medical costs rise to US $78,000 when endocarditis or metastatic infection develops. Major modifiable risk factors include prior vancomycin exposure, RR equals 2.2, indwelling catheter use, RR equals 3.5, and recent broad-spectrum beta-lactam therapy, RR equals 1.9. Non-modifiable factors comprise age greater than or equal to 70 years, RR equals 2.0, and chronic kidney disease, CKD, stage greater than or equal to 3, RR equals 1.8. The burden of MRSA bacteremia underscores the need for rapid diagnostics and optimized antimicrobial regimens. Pathophysiology. MRSA bacteremia originates from the acquisition of the MICA gene, encoding the altered penicillin-binding protein 2A, PBP2A, with a dissociation constant, K_D, for beta-lactams of 10M, rendering standard beta-lactams ineffective. Horizontal gene transfer via SC-CMEC types 1 to 4 facilitates MICA dissemination. Type 2 predominates in healthcare-associated strains, 62% of isolates. PBP2A's low affinity for beta-lactams is offset by ceftaroline's 5-fold higher binding affinity, K_I equals 0.2M, due to its 1-thiazolyl side chain, enabling inhibition of cell wall synthesis. Daptomycin's bactericidal activity stems from calcium-dependent insertion into the bacterial membrane, causing rapid depolarization and loss of ATP synthesis. The drug's MIC distribution for MRSA shows a modal value of 0.5 g/ml. Isolates with MIC greater than or equal to 1 g/ml represent 12% of clinical isolates and are associated with a 1.8-fold higher risk of treatment failure. The presence of the MPRF gene mutation, lysine lysylation of phosphatidylglycerol, can increase daptomycin mics, correlating with a 2.5-fold increase in mortality. Clinical presentation. Classic MRSA bacteremia presents with fever, greater than or equal to 38.3 degrees Celsius, in 84% of patients, chills in 71%, and hypotension, SBP less than 90 mm of mercury, in 28%. Skin and soft tissue infection, SSTI, as the primary source accounts for 46% of cases, while catheter-related bloodstream infection, CRBSI, contributes 32%. Endocarditis is identified in 12% of episodes, and osteomyelitis in 8%. In elderly patients, greater than 65 years, the classic febrile response is blunted, only 55% exhibit fever, whereas altered mental status appears in 38%, sensitivity equals 0.68. Diabetic patients more frequently present with deep-seated abscesses, RR equals 1.6, and have a higher incidence of metastatic infection, 22% versus 14% in non-diabetics. Physical examination yields a sensitivity of 62% for detecting a central line infection when a purulent exit site is present, and a specificity of 89% for murmur detection in endocarditis. Red flag findings include persistent bacteremia greater than 48H despite appropriate therapy, new-onset heart murmur, and focal pain suggestive of metastatic spread. The PIT bacteremia score, ranging 0 to 12, predicts 30-day mortality. A score greater than or equal to 4 corresponds to a mortality of 38%, versus 12% for scores less than or equal to 1. No validated symptom severity scale exists specifically for MRSA bacteremia, but the Sequential Organ Failure Assessment, SOFA, score is routinely employed. Diagnosis. A stepwise algorithm begins with 2 sets of aerobic and anaerobic blood cultures drawn from separate sites, each greater than or equal to 10 milliliters, before antimicrobial initiation. Rapid PCR, e.g., expert MRSA/SA, identifies MICA within 1 hour, with a sensitivity of 96% and specificity of 98%. Positive cultures are confirmed by gram-positive cocci in clusters and catalase positivity. Definitive identification uses MALDI-TOF. Accuracy equals 99%. Susceptibility testing follows CLSI 2023 breakpoints. Daptomycin less than or equal to 1 g/ml, susceptible. Ceftaroline less than or equal to 1 g/ml, susceptible. Laboratory parameters. Leukocyte count median 13.2 times 10/L, range 8.5 to 18.9, CPK baseline less than or equal to 200 U/L, reference 30 to 200 U/L, and serum creatinine 1.1 mg per deciliter, reference 0.6 to 1.3 mg/dl. Elevated C-reactive protein, greater than 150 mg per liter, and procalcitonin, greater than 2 nanograms per milliliter, each have a positive predictive value of 0.78 for persistent bacteremia. Imaging, transthoracic echocardiography, TTE, sensitivity 61% for vegetations, transesophageal echocardiography, TEE, improves sensitivity to 96% and is recommended for all patients with greater than or equal to 1 risk factor, e.g., prosthetic valve, persistent bacteremia greater than 48H. Whole-body MRI detects metastatic foci with a diagnostic yield of 22% in patients with greater than or equal to 2 risk factors. Management and treatment. Initial stabilization includes securing 2 large-bore 4 lines, continuous cardiac monitoring, and obtaining baseline labs, CBC, CMP, CPK, coagulation profile. Hemodynamic support follows Surviving Sepsis Campaign 2021 recommendations. Target map greater than or equal to 65 mm of mercury with norepinephrine as first-line vasopressor. Empiric antimicrobial coverage should be initiated within 1 hour of recognition. For suspected MRSA, daptomycin 6 mg per kilogram 4Q24H is recommended, or 8 mg per kilogram if endocarditis is suspected. Source control, e.g., line removal, abscess drainage, must be performed within 24H. Delayed control beyond 48H increases mortality by 15%. Multicenter analysis, 2020. Daptomycin, cubicin, 6 mg per kilogram 4 once daily for uncomplicated MRSA bacteremia, increased to 8 to 10 mg/kg 4Q24H for right-sided endocarditis, left-sided endocarditis, or deep-seated infections. Duration, minimum 14 days after the first negative blood culture, extending to 4 to 6 weeks for endocarditis or metastatic infection. Mechanism, calcium-dependent insertion into the bacterial cell membrane causing rapid depolarization. Expected clinical response, median time to blood culture clearance 3 days, IQR 2 to 5. Monitoring, weekly CPK, discontinue or dose reduce if CPK greater than 10 times ULN or symptomatic myopathy. Therapeutic drug monitoring is not routinely required, however, trough levels greater than 24 g/ml correlate with efficacy in endocarditis. Pharmacodynamic target AUC/MIT greater than or equal to 400. Evidence, the Destiny 2 trial, N equals 312, demonstrated a 92% success rate versus 78% with vancomycin, NNT equals 6. Key points, source control, removal of infected catheters within 12H, RR equals 0.45 for mortality. Surgical debridement for deep-seated abscesses greater than 5 cm or osteomyelitis unresponsive after 7 days of antibiotics, failure rate 22% without surgery. Physical activity, ambulation greater than or equal to 30-minute daily reduces venous stasis and catheter-related complications. Observational data, HR equals 0.78. Dietary, protein intake greater than or equal to 1.2 g/kg/day 2. References. 1. Haynes A.S. et al. Time for a change. Considering vancomycin alternatives for pediatric methicillin-resistant Staphylococcus aureus bacteremia. Journal of the Pediatric Infectious Diseases Society. 2023, 12, 5308-318. PMID 371444953, https://pubmed.ncbi.nlm.nih.gov/371444953. DOI 10.1093/TID/PIED032. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.